Hello everyone and welcome to our module on secondary hypertension. In the video on hypertension, I talk about how most patients with high blood pressure, about 90% or so, have what we call primary or essential hypertension, where the underlying cause is not clear. But the remainder of patients, about 10% or so, have high blood pressure that is secondary to some other disease process, and this is what we're going to focus on in this video now. Before I go any further, let me make an important general point about what determines your blood pressure. So the two major determinants of blood pressure are the cardiac output and the total peripheral resistance. If either of these two things here go up, that's what can cause high blood pressure. So there are a number of things that increase your cardiac output, but importantly, as we'll talk about in this video, anytime there's renal salt and water retention, that's going to raise the circulating volume in the body. It's going to raise the preload to the left ventricle, and that will increase the cardiac output. In terms of total peripheral resistance, the key blood vessels are the arterioles. Anytime there's vasoconstriction from catecholamines or the sympathetic nervous system, this will constrict arterioles, and that leads to a rise in total peripheral resistance, and that can raise the blood pressure too. In clinical practice, the most frequent cause of secondary hypertension that you'll see is chronic kidney disease. For example, this man here who is on dialysis is very likely to have high blood pressure. Over 80% of patients with chronic kidney disease of any cause will have hypertension. There are multiple reasons this happens with chronic kidney disease. One of them is that when the kidneys are sick, the kidneys retain more sodium and that raises the blood pressure. Patients who have chronic kidney disease also have overactivation of the renin-angiotensin-aldosterone system and the sympathetic nervous system. But for all these reasons, in clinical practice, when you take care of patients who have chronic kidney disease and chronically elevated serum creatinine levels, you are very likely to see secondary hypertension. Obstructive sleep apnea is a condition I talk about in videos in the pulmonary section, but it's a sleep-related breathing disorder where patients have apnea during sleep. It's often treated with a CPAP machine like this man is wearing on the slide here. And many patients who have sleep apnea have overactivation of their sympathetic nervous system, and that often leads to hypertension. And importantly, when you treat the sleep apnea, like with a CPAP machine shown here, this can reduce the blood pressure because the high blood pressure is being driven by the obstructive sleep apnea. It's a secondary form of hypertension. I talk about nonsteroidal anti-inflammatory drugs, or NSAIDs, in videos in the immunology section, but NSAIDs include all these drugs listed here on the slide. They are anti-inflammatory drugs which knock down inflammation, and they don't have a chemical structure of a steroid, so they are nonsteroidal anti-inflammatory drugs. And if patients take these drugs regularly, that can potentially lead to secondary hypertension. The reason for this is because these drugs inhibit the enzyme cyclooxygenase in the kidneys, and that enzyme produces prostaglandins. So when patients take lots of NSAIDs, they have less synthesis of prostaglandins. And importantly, PGE2, prostaglandin E2, is a renal vasodilator. So when there's decreased synthesis of PGE2, there will be constriction of blood vessels in the kidneys and less blood flow to the kidneys. So I talk about the glomeruli in detail in videos in the renal section, but in the glomeruli in the kidneys, there's an afferent and an efferent arteriole, and the afferent arteriole depends on prostaglandins to maintain flow. So when you knock out prostaglandins with NSAIDs like PGE2, then you get relative vasoconstriction of the afferent arteriole. That means less blood going into the glomeruli. So that vasoconstriction from NSAIDs can decrease the renal blood flow. It can also decrease the GFR. And when there's less renal blood flow and less GFR, the body's going to hold on to sodium and water. It's hard to excrete sodium and water, so more of it will be retained. And this can lead to hypertension. This can also exacerbate heart failure. So frequent use of NSAIDs is a classic trigger for an exacerbation of heart failure. Oral contraceptive pills, or OCPs, which I talk about in the reproductive section, contain estrogen and progesterone analogs. And these hormones can cause a mild increase in blood pressure. And so this is always a concern with giving women oral contraceptive pills if they already have high blood pressure, because the blood pressure can get even higher potentially on these medications. Pseudoephedrine is a drug sometimes given as a nasal decongestant to patients who have allergies or a runny nose for any reason. You can see that its chemical structure somewhat resembles epinephrine, and if you know that, it's an easy way to remember that pseudoephedrine is an alpha-1 agonist. In the nose, in a person who's got congestion, this can be a good thing because the vasoconstriction caused by pseudoephedrine will decrease nasal blood flow. But if the pseudoephedrine is absorbed systemically, it can cause vasoconstriction of arteries, and that can lead to high blood pressure. Cyclosporin and tacrolimus are immunosuppressants that I talk about in a video in the immunology section, but the way they work is by inhibiting an enzyme called calcineurin found in white blood cells like T cells, and that's what makes them powerful immunosuppressants. But they have effects on the kidneys that can lead to hypertension. First of all, they activate sodium chloride transporters in the kidneys, so the kidneys reabsorb more salt and water. They also cause some renal vasoconstriction. And so just like we talked about before, when there's less blood flow to the kidneys, less salt and water gets excreted and salt and water gets retained. So through both of these effects, cyclosporin and tacrolimus are both classic causes of secondary hypertension. And the drug of choice, by the way, for treating patients with hypertension from one of these drugs is diltiazem. Not only is it an antihypertensive drug, it also impairs metabolism of cyclosporin and tacrolimus. It raises the drug levels. So by giving the patient diltiazem, not only do you treat their blood pressure and lower it, you're also able to use a lower dose of cyclosporin or tacrolimus, so you get less side effects from the drugs. Okay, next let's talk about primary aldosteronism, which is a rare but classic cause of secondary hypertension. In this disorder, as the name implies, there are excessive levels of aldosterone secretion from the adrenal glands. Importantly, this is not caused by increased activity of the renin-angiotensin-aldosterone system. So for example, you may know that in heart failure, there's increased activity of the RAS, and that will cause high levels of aldosterone secretion. That is not primary aldosteronism. In primary aldosteronism, the RAS is not being overactivated, but yet the adrenal glands are excessively releasing aldosterone. There are two main reasons why this happens. The first one is when there's an adenoma, an adrenal tumor, that is secreting aldosterone. This is sometimes called Conn syndrome. And the second reason is when there's bilateral idiopathic adrenal hyperplasia. Basically, in this form of primary aldosteronism, for reasons that are poorly understood, both adrenal glands develop hyperplasia, they increase in size, and they release too much aldosterone. In videos in the renal section, I talk in detail about what aldosterone does, but I'll briefly review that here. So first of all, aldosterone increases the activity of sodium channels found in principal cells of the collecting duct. So this causes more sodium to be reabsorbed out of the urine into the principal cells. And then there's another aldosterone-sensitive pump which brings the sodium outside the cell. So the net effect is that aldosterone causes sodium to be reabsorbed out of the urine and back into the interstitium and blood. Aldosterone also causes potassium to be taken out of the blood and secreted into the urine. So it causes potassium to be excreted from the body. And then finally, aldosterone can activate proton pumps in the intercalated cells of the collecting duct, and this causes acid to be released into the urine. So aldosterone is important for acid secretion. And so if you understand the way that aldosterone works on cells in the kidneys, then it's easy to remember the clinical features of primary aldosteronism. So first of all, high levels of aldosterone are going to increase sodium resorption in the distal nephron. When the kidneys reabsorb more sodium, they reabsorb more water, so this is going to expand the effective circulating volume. That's going to raise the cardiac output, and that's what contributes to the hypertension. Importantly, though, and make sure you understand this, the serum sodium concentration is going to be normal. And that's because pituitary release of ADH is intact. So ADH is going to be released and water is going to be retained in order to maintain a normal serum sodium concentration. So these patients will have an expanded effective circulating volume and hypertension, but a normal serum sodium concentration. Now, as we just talked about in the last slide, aldosterone also promotes potassium excretion in the kidneys. So this can lead to hypokalemia. But now I want to put a little asterisk here next to hypokalemia, and that's because in clinical studies, half or more of patients with primary aldosteronism have a normal or low normal serum potassium level. And the reason for this is because the potassium level in the plasma varies with intake of sodium and potassium. So it's not always low in patients with this condition, even though you would expect hypokalemia based on the mechanism of action of aldosterone. And then finally, as we talked about, aldosterone promotes acid excretion. So in primary aldosteronism, you expect a metabolic alkalosis and a high serum bicarbonate. And so I've summarized over here the lab findings that you'd expect in a patient who has primary aldosteronism. Very high yield to understand these for step one. You might think that in primary aldosteronism, because the kidneys are retaining sodium and water, that patients would be volume overloaded. And by this, I mean that they would have swollen ankles and pulmonary edema and elevated jugular venous pressure when you examine their neck. But it turns out you don't see any of these features. And that's because of a phenomena called aldosterone escape. So this refers to the fact that in primary aldosteronism, excess aldosterone does not lead to volume overload, and you don't get these clinical findings shown here. The only thing that happens from the sodium and fluid retention is hypertension, but none of these physical exam type findings shown here. The reason this happens, the reason there's aldosterone escape, is because in primary aldosteronism, compensatory mechanisms are activated, especially increased atrial natriuretic peptide release from the heart. And this causes increased sodium and free water excretion, so the patient doesn't get volume overloaded. They have a normal volume status. The only evidence on examination that they have high aldosterone levels is going to be the hypertension, but you're not going to see any of these signs of volume overload. So putting this all together, the clinical features of primary aldosteronism that you want to know for your board exams is that, first of all, these patients will have resistant secondary hypertension. So their hypertension is notoriously hard to treat. It won't respond to one or two drugs. That's called resistant hypertension, and that's one of the signs of primary aldosteronism. In addition, when you do lab testing, you find hypokalemia and an increased bicarbonate. And then, as I said on the last slide, there's a normal volume status on physical exam. To make the diagnosis, you have to demonstrate that there's renin-independent release of aldosterone from the adrenal glands. So there are two tests we use to show this. The first is measurement of the plasma renin activity. That should be low. And then you can measure the aldosterone levels, and that should be high. And so these two findings right here are super high yield to understand. This is what you expect in a patient with primary aldosteronism. The drugs of choice to treat primary aldosteronism are spironolactone and eplerenone. These drugs are aldosterone antagonists. They will block the effects of those high levels of aldosterone. They will bring down the blood pressure, and they can normalize the potassium and the bicarbonate level. Importantly, and it's super high yield to know this, ACE inhibitors and angiotensin receptor blockers have no effect in this condition. Why is that the case? Well, remember, their adrenal glands are producing lots of aldosterone, and that is leading to salt and water retention. And as a result, their RAS is dialed way down at baseline. That's why they have a low plasma renin activity when you measure it. So the RAS is already dialed down, and they're producing very low levels of angiotensin II. So if you block the RAS with an ACE inhibitor or you block angiotensin II with an ARB, it has no effect because the levels of angiotensin II are already very low. And in these patients, the aldosterone release that is causing their problem is not dependent on angiotensin II. So inhibiting angiotensin II's activity with one of these drug classes usually has no effect. Make sure you're clear in your mind on the difference between primary aldosteronism and secondary aldosteronism. So in secondary aldosteronism, there are also high levels of aldosterone, but in this case, they're caused by overactivation of the renin-angiotensin-aldosterone system, the RAS. Anytime the RAS gets activated or overactivated, that leads to high aldosterone levels. But in this case, this is not primary aldosteronism, it's secondary to the RAS. This can present with a similar clinical syndrome to primary aldosteronism. These patients can have hypertension and hypokalemia and high bicarbonate levels. But when you do the blood tests, you will see that the plasma renin activity is high, not low, and the aldosterone is also high. And it's this high plasma renin activity that is key to letting you know that this patient has secondary, not primary aldosteronism. What are some of the causes of secondary aldosteronism? Well, one of the major ones is renovascular hypertension. And by this, I mean those patients we talked about earlier in this video, patients with chronic kidney disease, they chronically over-release renin, and therefore they can have secondary aldosteronism. You can also see overactivation of the RAS in a number of clinical conditions that I talk about in other videos. So in heart failure, in cirrhosis, in nephrotic syndrome, in all of these cases, the RAS is overactive, and that can lead to secondary aldosteronism. And then it's rare, but there are renin-producing tumors that sometimes occur, and these also lead to secondary, not primary aldosteronism. Besides primary and secondary aldosteronism, there's one other condition that can present the same way with hypertension and low potassium and high bicarbonate levels, and that condition is called Little syndrome. Little syndrome is a rare genetic disorder, and children born with this condition have increased activity of ENaC channels. ENaC stands for epithelial sodium channels. These are those aldosterone-sensitive sodium channels we talked about before that are found in the collecting duct. So if we go back to this slide, these channels here are the ENaC channels, and they're overactive in children born with Little syndrome. That leads to reabsorption of sodium, just like you see in aldosteronism. And because all these channels are linked, when there's overactivity of the ENaC channel, you get more secretion of potassium. You also get more secretion of acid, and therefore you get the same clinical findings as in primary or secondary aldosteronism. So as I said, this can be a similar clinical syndrome to other forms of aldosteronism. The patient can have hypertension, hypokalemia, and a high bicarbonate level. It can present in childhood, which is unusual for high blood pressure. And then importantly, this is the thing you want to know for step one, the aldosterone levels are low. So if the patient has these clinical findings and it looks like some form of primary or secondary aldosteronism, but then the test results show this, low plasma renin activity and low aldosterone, this is the time when you want to think of Little syndrome. In videos in the endocrinology section, I talk about pheochromocytomas, which are very rare tumors that produce catecholamines like epinephrine, norepinephrine, and dopamine. And these catecholamines can raise the blood pressure, and so pheochromocytoma is a very rare but potential cause of secondary hypertension. Usually these tumors arise in the adrenal glands, and classically they cause the triad of palpitations, headache, and episodic sweating, all related to high catecholamine levels. And some people remember this by the PHE in the name of the tumor. Most of the patients also have hypertension. That's why we're talking about it here in this video on secondary hypertension. And you can make the diagnosis by identifying catecholamine breakdown products in the urine, things like metanephrines and VMA. And once again, I talk about all this in more detail in the video in the endocrinology section. Another endocrine disorder, Cushing syndrome, can lead to secondary hypertension. In Cushing syndrome, patients have excess cortisol. Often this is because they're taking steroids as immunosuppressants, but there are other reasons why patients can have high cortisol levels. In Cushing's disease, the pituitary gland is overproducing ACTH, and this causes the adrenal glands to produce excess cortisol. There are also some tumors like small cell lung cancer that sometimes make ACTH, and then rarely there can be an adrenal tumor that produces cortisol, but in all these cases you're going to have high cortisol levels. And the high cortisol levels lead to hypertension. They cause increased vascular sensitivity to adrenergic agonists like epinephrine and norepinephrine, and I talk about all this in more detail in the endocrine section. Okay, another classic cause of secondary hypertension is renal artery stenosis. So this refers to vascular disease of the renal arteries where plaque builds up and there's narrowing and decreased flow to the kidneys, and the kidneys respond by raising the blood pressure and retaining sodium and water. And so a key exam finding, especially in board questions for renal artery stenosis, is the presence of a renal bruit. You can hear this with your stethoscope, and that's a clue that there may be vascular disease in the renal arteries. So when there's decreased blood flow to a kidney, that kidney will respond as if there's low circulating blood volume. So that kidney will release more renin, it will retain salt and water, and all these things can lead to hypertension. Often there's unilateral stenosis, and when this happens, the normal kidney compensates. And so as a result, there are no signs of volume overload. So you don't see lower extremity edema and pulmonary edema. The only finding you'll have that indicates possible renal artery stenosis will be the hypertension, plus possibly a bruit when you listen with your stethoscope over the kidneys. So here's a cartoon just to give you a picture in your mind of what's happening in a patient with unilateral renal artery stenosis. So one kidney has narrowing of the renal artery and decreased blood flow. That's the stenotic kidney. And so that kidney is sensing low blood flow, so it's going to release lots of renin, and it's going to retain sodium, and that's going to lead to increased activation of the RAS and high blood pressure. The normal kidney, however, will sense the high blood pressure, and it will cut back on its renin release, and it will secrete more sodium into the urine. So these things kind of balance out, and what you're left with is euvolemia, meaning no edema in the ankles, no pulmonary edema, but the patient will still have high blood pressure, and therefore high blood pressure is usually the only major finding of unilateral renal artery stenosis. It's super high yield to understand that in renal artery stenosis, angiotensin II is very important, and ACE inhibitors can be very bad. So remember that if you've got a glomeruli, you have an afferent arteriole and an efferent arteriole. And I go over all this in detail in videos in the renal section. But when there's decreased blood coming in because of renal artery stenosis, what the efferent arteriole is going to do is constrict. It's going to tighten up here. And that's going to cause the pressure to rise behind that narrowing, behind the vasoconstriction. And that's going to drive blood from the glomeruli into the nephron. And this is what's going to keep the kidneys working. Well, if you give an ACE inhibitor and you block the production of angiotensin II, all of a sudden this vasoconstriction goes away. Now the pressure falls a lot because remember, there's less blood coming in because of the stenosis, and now you don't have constriction of the efferent arteriole, so you get very low pressure in the glomeruli, very little blood will get filtered into the nephron, and so this can precipitate renal failure. So once again, high yield to know that angiotensin II is very important in renal artery stenosis, and ACE inhibitors can be very bad, causing renal failure. Most patients who develop renal artery stenosis have typical risk factors for vascular disease, so things like older age and hypertension and diabetes or smoking. But there is a rare cause of renal artery stenosis that occurs in younger, healthier patients, and that causes fibromuscular dysplasia. So fibromuscular dysplasia, or FMD, is a vascular disease that leads to obstruction of flow through blood vessels. It's common among women, and it occurs at a relatively young age of the 40s and 50s. The reason these blood vessels have decreased flow has nothing to do with atherosclerosis, and it's not inflammatory. What happens is that for reasons that are poorly understood, the medial layer of blood vessels develops fibroplasia, meaning excessive growth of fibrous tissue. So remember that blood vessels have three layers: an intima, a media, and an adventitia, and it's this middle or medial layer that develops fibroplasia in fibromuscular dysplasia. This leads to narrowing or stenosis of blood vessels. It also weakens the walls of blood vessels, so aneurysms can occur. And when these things happen together, stenosis and aneurysms, it looks like a string of beads on imaging. This is a picture of an angiogram of the renal arteries in someone with fibromuscular dysplasia, and you can see these round bumps here. The stenosis areas are here, and the bumps are caused by aneurysms. The most common locations for stenosis and aneurysms in FMD is in the renal and carotid arteries, and so it can lead to renal artery stenosis. And this is a diagnosis you want to think of in a younger patient who has resistant hypertension and has abnormal imaging of their kidneys, like what's shown on the slide here. I have a whole video in the cardiology section on coarctation of the aorta, but I just want to mention here that in coarctation, there's a congenital narrowing of the aorta, and this is one potential cause of secondary hypertension. And then I'll finish this video with one slide on autosomal dominant polycystic kidney disease, or ADPKD. I talk about this in more detail in videos in the renal section, but ADPKD is a genetic disorder caused by mutations of PKD1 or PKD2, which are two genes related to kidney development. It presents in adulthood with hypertension and cysts on imaging of the kidneys. That's why it's called polycystic kidney disease. And these patients have high RAS activity, and that leads to hypertension. And that's why I'm including it here as a potential cause of secondary hypertension. And that concludes our module on secondary hypertension.